I have the honour of introducing our next speaker. So some of you may have actually seen him in his workshop yesterday. I'm told it was fantastic. A lot of the rest of you are going to see him this afternoon or tomorrow, and if you're tomorrow, you're with me. So our next speaker is Ron Alexander. He's the director and founder of the Functional Fascial Taping Institute in Melbourne. Ron has also, really interestingly, served for 8 years as the principal soft tissue therapist for the Australian Ballet, of which he was awarded the Lady Selby Scholarship for Excellence. Ron is actually now turned his attention towards research, and he's going to share with us his co-investigation of FFT on people with non-specific low back pain. Please welcome Ron to the stage.
Hi, thank you for all coming. I'd like to thank AAMT for asking me here. I discovered FFT in 1994 and I've refined the technique ever since. My paper today is on the effect of FFT, or functional fascial taping, on pain and function in patients with non-specific lower back pain, and it was a randomised controlled trial. We published in Clinical Rehabilitation in October of 2012. For those of you who don't know what FFT is, it's a fast and effective way to decrease pain and increase function, which encourages normal movement patterns and rehabilitation in a pain-free environment. Published case study in your notes is of a lower back pain patient. I presented this with the 3-year follow-up at the Fascial Research Conference in 2007 as a poster. This was the test case that Dr. Jill Cook, who referred to me to see if FFT would get a randomised controlled trial. 4 weeks later, it indicated to her that her RCT was warranted on FFT. For people who don't know what non-specific lower back pain is, it's categorised as people who have back pain for more than 6 weeks and less than 12 months. It can't be given a clear diagnosis, and 85% of lower back pain cannot be given a clear diagnosis regardless of any scans and imaging. 80% of people will get lower back pain at some time in their life. 90% of these people will get better within 6 weeks regardless of treatment. 10% of these people will go on to have lower back pain for up to 12 months. It was conducted at Deakin University in Melbourne, and our principal supervisor was Dr. Jill Cook and Professor Sing Kai Lo. Our co-investigator was Shumei Chen, and she was also the outcome assessor. Our study was a randomised, double-blind, placebo-controlled trial. The clinical trial went for 20 months. And what the double-blind means is we have one group, which is the intervention group, and we have another group, which is the placebo, or the control group, and we compare the data. And why it's called blind is we don't tell the people what group they're in. And the outcome assessor is also blind to which group the people are in. This is a chart for our randomisation, recruitment and follow-up. We advertised through medical practices, paramedical clinics, and we advertised in the newspaper. We published an article. This article got the most amount of people. As you can see, I had a particularly bad hair day, and it looks like I had an extremely big lunch, so we'll move on from that. We had 96 people who telephoned. They went through our selection criteria. 48 people entered initially, and then 5 dropped out before the study started. We obtained consent, and also we went through the randomisation process, and we had 43 patients. We had 21 FFTs, and we had 22 placebo. In the first 2 weeks of the intervention, we had 2 people in both groups drop out. And then before 6 weeks, we had another 2 people in the FFT group who dropped out. The people who completed this study were 17 FFTs and 20 placebos. Our demographic characteristics and baseline outcome measures. Baseline means at the start of the project. We mark all the information from the patients then, and then we can use that as our guide to how effective we've been. characteristics of age, weight and so forth, and our baseline outcome measures of worst pain and average pain. All the mean of that data were very similar between the groups. They had to exhibit a flexion deficit, and we used all the key prognostic indicators for lower back pain. I treat them 4 times over the initial 2-week period, and they have to keep the tape on. We assess them after 2 weeks, then they're assessed again by prognostic indicators at 6 weeks. At 12 weeks, we get back together, then they're assessed for blinding, and then they're given the envelopes to tell them what group they're actually in. This is our treatment procedure that we followed. So everything is standard, except the way it's applied is different. So I've cleaned the skin down with a rubbing alcohol solution, and then I used a barrier layer application. It's a hyperallergenic adhesive. And I took the label off, so I had a yellow bottle, and this could have been the magic potion that we're actually investigating, and it's really important for the placebo group that they had that. Then I put the white hyperallergenic underwrap tape on, and then we've used 3 pieces of rigid tape, half width wide, and I'll explain that in question time, if you like, why I'm doing that. And then we put the white tape over the top, which is a hyperallergenic. Then I give them lumbar flexion exercises in the 2nd week, and we also give them a flyer as to skincare advice. These are 2 patients from in the placebo group, and they sit there in the pain provocative position, and I use a caliper and I measure length by width of the actual pain. I do some calculations like I'm actually working something out, and then just put tape on their back, following that process that I spoke of. And obviously with tape we're getting proprioceptive input to the central nervous system, and then psychological placebo effect of the patient's expectation to treatment. And in the 2nd session and 3 and 4, they're all the same. I get the patient to flex forward, they reproduce their pain, I measure the area, and then I put the tape on that area. And then they see if they can go more forward, then I take the photo. On session 2 or 3, we had to bring a partner or a friend in to learn how to reapply the tape for them because it's on their lower back. These are some patients in the FFT group. I followed exactly the same process. They're sitting in the pain provocative position again. In this group, I assess the tissue directly over the pain. This is similar to Andrew Still to determine the best direction at ease, and then apply the tape from that point going away with a gathering technique. What we're doing here is we have directionally specific load and obviously proprioceptive input and the expectation to treatment. In the 2nd session, 3 and 4, so they're flexing forward, I'm distracting the tissue, then loading in that direction, and then they go forward, I take the photo. And the partners also taught as well. So, the results from our 430 treatments. This is an ANOVA table, which is 5 different repeated measures. And we're looking at change in pain and function within and between the groups. We're looking at worst pain, and I'll explain that in a moment. Here, average pain and the modified Os-Westry, it is similar through the data, so there's no point talking about that. Worst pain, you can see we've got 0, which is baseline, and then we have 2, 6 and 12 weeks. This is the mean of all the people in the FFT group, placebo group, and then we've got the mean of all the data between the change between these. Here is our p-value. Our study was set. They have less than 0.05 our p-value for it to be clinically significant, and it's 0.02. I know I'm talking about very small numbers, but this is actually a percentage. So what it shows is that we've got clinical significance. In that 0.02 is actually 2%. 2% chance, and 98% of the time it's happened through the intervention. Also have the study set at 0.5 for the effect size. So we've actually got 0.74, really a quite high figure. It's clinically significant. And this figure was also confirmed by a 95% confidence interval. So what that means is that the number had to fall within these digits here and also have not crossed zero. That's clinically significant. So we've actually found something. This table here is the number of people who attain minimal clinical important difference, or MCID, and I'll explain that in a moment. And we're looking at pain, intensity and function between the groups, and it was measured over time. MCID is if you have a visual analog scale, 0 to 10 and 10 being the maximum pain. If they come in at 7 and you treat them and they, at the end of the treatment they have less than 5, that's clinically important. So at 2 weeks, the people who attained this in the FFT group were 17 people. So all the people who stayed in the study attained it. And the people who did not are the 4 people who dropped out. The placebo group, we had 2 people who dropped out and we had 9 who attained it. Our p-value had to be less than 0.05 and it was really high at 0.007. The p-value, what that's actually saying is that 1,000 times you run a project like this, 993 times you'll get a similar result to what we've actually got. And that's including the dropouts. All the data here over the weeks is showing very similar figures. So what's happening is the placebo people are having their natural effect over time of getting better. This is the Modified Oswestry Disability Index, and all the data is very similar and the same high p-value figure as well. Our conclusion that we can draw from this, FFT reduced worse pain with patients with non-acute, non-specific lower back pain at 2 weeks. And pain, intensity and function with MCID was significantly greater in the FFT group at 2 weeks. The mechanism can only be hypothesised at this stage, and I'll talk about that in a moment. The change occurred between the groups, maybe the natural placebo effect, because there's a chance that it may have happened through placebo in our intervention with the FFT. Our data suggests otherwise. In clinical practice, lower back pain is a complex musculoskeletal condition and it is multifactorial in nature. What FFT does is it allows a window of opportunity where you may be able to take a step further in your treatment. And of course you're doing other treatments and you're doing other rehab advice. We're following a reductionist model, which is what you do with research, to try and identify what's making the change. Our hypothesis that we've drawn from this, the assessment procedure has pain-specific direction variability, which may indicate the neurofascial interface. This may stimulate large diameter afferent fibres and then modulate nociceptor input. The load from the tape, or the tape whilst it's on the body, potentially may affect the skin and or remodel the internal architecture of the connective tissue, which includes the fascia, and this may change mechanoreceptor activation. Our hypothesis is supported by another paper on motor synchronisation that was published, PhD in Queensland. Our project looked at observing the effect of FFT over placebo, and there is more research that is needed, but we're following the scientific approach of showing an effect first, and now we're open to investigating how it comes about that it makes the change. I'd just like to thank the team at Deakin University. The tape was supplied by the Australian Centre for Research that's supported by the International Olympic Committee and also Medical Kinetics in Australia. They had no input into any of the data, and I'd like to thank you for not going for an early lunch break. Thank you.
We've got time for questions, so as the same as last time, first hands up, best dressed. We've got one in the middle.
Hi. I was wondering how many people reacted to the tape.
This patient, she was the only one who reacted to the tape. It happened down around here, and the good thing is when she came back, the pain had reduced to this area, so it was fine. they were also, that was a part of our screening process if they were ruled out of any skin conditions.
Why did the dropouts drop out?
Oh, yes, interesting. If you go to here, we had 4 in the two in the placebo group dropped out because they worked out they were in the placebo group and they left. 1 in the FFT group thought they were actually in the placebo group and they left. Another one in the FFT group, by the end of 2 weeks, he required back surgery. So the FFT removed the soft tissue component, which revealed an underlying sinister pathology, and he had to have surgery. And the other 2 got better, had learnt how to do the technique from their friend had, and they left the study. The most important thing is here is their data stays in the study. They become a nil result. So they're scratched, but their data stays in the study for the whole study.
I'd just like to thank you for your presentation today. Sorry. Is this one?
No.
There's your work on the other.